rating scale, which increases with functional decline to account for differences in progression across the groups of those with psychosis and those without psychosis. So using ADNI data, we found 26 people who had endorsed psychosis and how tau PET performed. For the purposes of this analysis, we defined psychosis based on endorsement of either delusions and or hallucinations on MPI or MPIQ, which is a subjective measure. We then matched each individual based on age, gender, education, race, and global CDR with a participant who had never endorsed psychosis. Our final cohort was comprised of older adults, about half women, and notably those patients with psychosis were mostly in CDR.5 and CDR1. So tau PET data was processed according to ADNI methods. T1 MRI was used to generate free surfer labeled regions of interest, and non-PVC values were used. We looked at BRAC composite regions, shown here. So we looked at BRAC stage 1, 2, 3, 4, and 5, 6 for our AD regions. And we also looked at regions known to be related to psychosis due to other etiologies, such as the amygdala, hippocampus, frontal lobes, temporal lobes, and parietal lobes. So we also performed a voxel-wise comparison made based on group-level differences. All analyses were corrected for amyloid level based on PET-derived centiloids. And finally, we performed a qualitative assessment based on type of psychotic symptom. So we started by looking at BRAC regions. In dark blue on the left are non-psychosis participants, and in light blue on the right are the participants with psychosis. So BRAC1 is composed of the hippocampus and was found to be significant. Interestingly, previous studies found significant differences in later BRAC stages, 3, 4, and 5, 6. But when we matched groups across CDR accounting for disease progression, there no longer appears to be a difference in these late stage BRAC regions. So here, these two are not significantly different. Next, we look at the same data, but along regions known to be associated with psychosis due to other etiologies. And we found that tau signal was significantly higher in the hippocampus and the amygdala for the psychosis group versus the non-psychosis group. And furthermore, the effect size of the amygdala was about 2 times greater than that of the hippocampus. So we wanted to explore this further and performed voxel-wise analysis. On the left here is an unadjusted model between matched psychosis and non-psychosis groups. Shown in green are significant voxels where tau was elevated in those with psychosis versus no psychosis. And clusters were found in the amygdala, hippocampus, and the thalamus. We did also see some off-target binding differences between the groups. So in red, there would be voxels where tau was higher in those without psychosis, but no significant voxels were found in that opposite direction. So the model on the right here is corrected for amyloid using centiloids, as a variation in amyloid level may be another reason for differences in elevated tau between groups. Potential unilateral clusters of significant voxels appear here in the frontal lobe, in addition to the survival of significant voxels in the regions I mentioned, the amygdala, hippocampus, and thalamus. So next we wanted to qualitatively explore the temporal relationship between when participants experienced psychosis and when they had their tau scan. So shown here are averaged SUVR images of those with no endorsement of psychosis, endorsement of psychosis after their tau scan, endorsement of psychosis prior to their tau scan, and then concurrent hallucinations or delusions. So on the left, those without psychosis show a typical BRAC-like pattern that we would expect for CDR.5 and 1 with slightly elevated tau in the lateral temporal lobes, as this group is primarily comprised of CDR.5. And those with concurrent delusions had more visually prominent tau signal than any other group. And this is notable given the fact that this group is entirely comprised of a CDR 0.5 and 1. So for each of the other psychosis subgroups, they showed less signal in the temporal lobes and then some specific focal spots. So we do not believe that tau is somehow transient and only elevated during psychotic episodes, but we do believe that this is pointing to differences in tau signal patterns that may be distinct across different psychosis subtypes and needs to be explored further. It's also worth noting that there is a lot of heterogeneity within each of these groups, so longitudinal tau scans may help in determining development and progression of AD patients with psychosis, especially because individual patterns are likely specific to individual symptom profiles, such as auditory versus visual hallucinations. So this box plot further shows the regional SUVRs, but now broken down into the subsections of psychosis that we were just discussing. We can see a stepwise pattern here in the amygdala that is still sort of seen in the hippocampus, but I think this suggests that these significant differences we're seeing are driven by those who are experiencing concurrent psychosis. So our key takeaway is that even in this unique sample of patients with low CDR and psychosis, we still found a neuroimaging signature of elevated tau in the amygdala and hippocampus. This is similar to limbic and cortical regions that have been observed via neuroimaging, plasma, CSF, and pathology in studies of later onset psychosis within AD, which typically happens around CDR2. So this tau signature is likely only one part of a larger multimodal neuroimaging signature of psychosis in AD, and gray matter volumetrics or white matter conductivity may help provide insight into how tau may be affecting the brain structure and function, potentially increasing an individual's susceptibility towards developing psychosis during their AD progression. So moving forward, we think that longitudinal tau scanning can help us understand how specific patterns of tau relate to the onset and progression of specific patterns of psychosis symptoms. And we're also interested in looking into the effective family history of psychosis, treatment plans, and also drug responsiveness. So with that, I want to thank the participants within ADNI, all of my colleagues at Columbia, some of whom are here today, and the funding sources, and all of you for your attention. Thank you. Alrighty. Next, I want to introduce my co-chair, Lisanne Jenkins from Northwestern University, giving her talk, Structural Brain Network Degeneration Associated with Agitation in Dementia.
Thank you, and I have no disclosures. I'd like to thank my co-authors who helped work on this project with me. Okay, so agitation in dementia is a behavioural syndrome that involves increased motor activity, aggressiveness, emotional distress and restlessness. And across multiple forms of dementia, it's got a prevalence of around 30%. It's associated with several negative outcomes, including reduced quality of life, caregiver distress, and even mortality. And there's only been a limited amount of neuroimaging research performed looking at agitation, and that which has been done tended to focus on regional analyses. And these studies have found results in regions within the salience and cognitive control networks. However, I think it's important to understand the brain network topology, as this could provide insights into potentially novel new treatment methods. So I was interested in identifying whether agitation in dementia was associated with reduced integrity of the salience and cognitive control networks, regardless of the dementia syndrome. So one relatively new and robust method for studying brain networks is known as morphometric similarity networks. So this method takes a T1 weighted MRI and then uses FreeSurfer to parcellate the brain into the surfaces and then into parcels, sorry. And so for each of a set of parcellated region, statistics are calculated on topological features, including grey matter measures such as cortical thickness, as well as measures of curvature and folding. So this results in a feature vector for each parcel, and then this feature vector is correlated with every other parcel's feature vector to result in a structural connectome or matrix of interregional similarity. So what you get is a morphometric similarity matrix or MSN for each individual participant. So for this particular study, I obtained participants from ADNI as well as a corresponding frontotemporal lobar degeneration neuroimaging initiative dataset, as well as participants from the Mesulem Centre for Cognitive Neurology and Alzheimer's Disease at Northwestern. There were 210 individuals with mild cognitive impairment, 104 with dementia of the Alzheimer's type or DAT, and 75 with behavioural variant frontotemporal dementia or BVFTD, and 212 cognitively normal individuals. And these were all just clinical diagnoses, so not autopsy confirmed. And across the different types of dementia syndromes, the prevalence of agitation varied from 25% in the MCI group to 43% in DAT and 60% in the BVFTD group. And there was even a 7% prevalence in the cognitively normal individuals. This shows the breakdown of the NPI-Q measure of agitation by diagnosis. So to the right of the line are individuals with presence of agitation. So you can see most were mild and some moderate, and severe was mainly present in the BVFTD group. So for this particular study, I used the 360 parcels from the Glasser Atlas, and I then used the G et al. Functional Atlas to assign each of the parcels to a functional network. I defined the cognitive control network as comprising the frontoparietal and dorsal attention networks, and the salience network as comprising the singular opercular and orbitoaffective networks. Thresholding is often performed on connectomes to remove weak or spurious connections, and for this study I chose thresholds of 0.25, 0.3, 0.35, 0.4 and 0.45, and these thresholds were chosen to avoid disconnected networks as well as networks that displayed small world properties, meaning that they reflected an optimal balance of network integration and segregation. So I calculated two measures of graph theory for this analysis, and these were transitivity and global efficiency. Transitivity is a measure of network segregation, with more segregation in high transitivity, whereas global efficiency is the measure of network integration, with more integration happening in networks with higher global efficiency. For my statistical analyses, I was interested in identifying whether there was a significant main effect of agitation presence on the network measures, and I also wanted to identify whether there was a significant interaction with diagnosis. So I calculated 4 repeated measures and COVAs. The dependent variables were transitivity and global efficiency within the salience and cognitive control networks. So these were 2 presence or absence of agitation by 4 diagnosis and COVAs, with threshold as the within subject factor, which I included only to ensure that my results were not threshold dependent. And the covariates were age, sex, race, education, database, intracranial volume, dementia severity, as well as days between the MRI and the NPI-Q. So, for my results, for the salience network global efficiency, there was a significant main effect of agitation. So in these figures, the lines in red indicate individuals who have agitation, and the lines in blue are the individuals without agitation. So you can see that across the various diagnoses, people with agitation had lower global efficiency of the salience network than those without. However, there was also a significant main effect of diagnosis, and post-hoc tests found differences between the cognitively normal and MCI and DAT groups, and the MCI differed from BVFTD and DAT differed from BVFTD as well. However, the interaction effect was not significant. For salience network transitivity, there were no significant main effects or interactions. But for the cognitive control network transitivity, there was a significant main effect of agitation. So again, the line in red here, the lines in red show agitation presence. And so people with agitation had lower cognitive control network transitivity than individuals without. And post-hoc tests found that the difference was significant only for the BVFTD group. So BVFTD with agitation had lower cognitive control network transitivity than those without. This time there was no significant main effect of diagnosis and no significant interaction. For global efficiency of the cognitive control network, there were no significant main effects or interactions. So, to summarise, we found evidence that agitation is associated with reduced integration of the salience network and reduced segregation of the cognitive control network, regardless of diagnosis. However, there was a lack of significant post-hoc tests other than for the BVFTD group. And this is likely due to the relatively low levels of agitation in the cognitively normal and MCI groups, which is a limitation but not really unexpected. Our results are consistent with the relatively few neuroimaging studies on agitation, and our limitations include the fact that morphometric similarity networks are only a proxy for connectivity, although they have been shown to recapitulate known psychoarchitectonic divisions and tracks from macaque track tracing studies. Further research should look at resting state functional connectivity, as well as the importance of subcortical structures that are important, particularly for the salience network, such as the amygdala. And so finally, I'd love to hear from you or connect with you. If you have questions or are looking to collaborate, please don't hesitate to get in touch. And be sure to check out some of the posters from other individuals in my lab at AAIC, including Ashley Haywood, who won one of the awards for Best Oral Presentation at AAIC, as well as Jane Stocks, who's a new postdoc at the Mechelen Centre at Northwestern. So thank you.
Questions? Okay. So she's not.
So we have heard that the other talk from Jessica Groth will not be happening. So we're ready to open it up to questions to all of the panel.
Maybe while we're waiting.
Maybe.
There's okay.
Number 4?
Yes.
Hello. One of the things I've always been struck by, Melissa Murray from Mayo Clinic, is the differences in some of the symptomology that we see in Alzheimer's being later with some of the psychiatric disturbances, and then earlier with the dementia with Lewy bodies. Dr. Sperling, or Dr. Almost Sperling Johnson, do we think about disease duration when we're matching, or what that would help and to inform upon?
Yeah, that's a great question. We definitely were concerned about DLB as, the fact that some of these participants may have DLB as a co-pathology. That's one of the reasons, though, why we considered amyloid level for each of these participants as well. But that is definitely a consideration. I think that'll need some more exploration. But thank you for the question.
Thanks.
Yeah.
Number 2.
Sure. Hi, I'm Ashley from Northwestern. I had a question for Laura, actually. What do you make of the laterality differences that you saw in the frontal findings? You saw more on the right than the left, is that correct?
Yeah, that's correct. So we did see them more on the right and the left. I think we need to assess a little bit more whether or not this is truly unilateral. There were some significant voxels on the left side as well, but it is consistent actually with some of the white matter tract findings in the right for schizophrenia research. So I think we're planning on diving a little bit more into that with white matter connectivity studies. Thank you.
Number 1.
Hi, thanks for your talks. I'm Amador Macias from Mexico. And I would like to ask you, the patients with agitation, they were on medication, and if the results may influence by the medications, antipsychotics or antidepressants?
Well, that's a good question. I did not look at that. I could pull that data out though, and that's something that I should definitely look at. Thank you. Number 5.
Hi, my name is So Young from Brigham and Women's Hospital. I have a question for Jeffrey. I wonder if this association is adjusted by either CDR or cognitive function to make sure that we're really looking at the effect of amyloid pathology, not like functional impairment.
So no, it's not actually. That's for the answer, the short answer. The longer answer would be we tried actually to separate the clinical groups, so to make this kind of thing in the clinical groups. And if I remember correctly, we observed this mainly in the MCI group. So it was replicated mainly in the MCI group. But no, it was not corrected for that.
So there are some questions online, and so I have one for Douglas Leffer. How do you think long-term use of ADHD medication may affect the associations you found?
Yeah, that's a great question. It's an open question in the literature. So the data that we used the genetic risk as a proxy of ADHD pathology. So those individuals, they did not have a diagnosis of ADHD, and therefore they were not treated for ADHD. So we still don't have the data to answer this question. However, some people suggest that medications might be protective against this effect, having in mind that one of the hypotheses is that individuals with ADHD may have decreased cognitive reserve, and maybe that's the reason they might be more prone to develop Alzheimer's disease and mild cognitive impairment. However, we honestly don't have the data for now to answer this question. We'd have to wait for the longitudinal studies to get old enough.
And there's another question for you. Why did you include ADPRS as a predictor in your multivariate regression model instead of using, for example, AD biomarker levels?
Yeah, that's a great question as well. So one of the not criticism, but one of the comments that we have in our first paper was that maybe we were not controlling for the genetic risk of Alzheimer's, and maybe we would have maybe some SNPs that were shared on some genetic comorbidity that was shared between both conditions, and that might be a confounder. So that's why we controlled for that, and actually the results were quite similar with and without the Alzheimer's polygenic risk score. We also had data in which we were able to control for some AD biomarkers. Unfortunately, the sample size was slightly lower, and for the sake of time, I didn't present this data, but basically, it seems like the results are quite similar if you control for the biomarkers as well.
I had a question for our virtual speaker, but I don't know if I can ask it. I was interested in learning about the pixel-based analysis, but
I don't think she's attending.
She's not joining for the Q&A. Okay, never mind.
I had a question for Joffrey. How did you determine, maybe I missed this, but how did you determine amyloid status based on PET?
Oh yeah, we used the cutoff for Plan Beta PET, actually the one from Lando, yeah, I think.
Okay, okay. Do you remember if it was like a conservative cutoff or if it was just, I've noticed as some of these talks that, in terms of centilloids were moving lower and lower. So I'm just wondering if it was sort of a more conservative cutoff or how that was determined.
I don't remember off the top of my head, to be honest, but I wouldn't say it's more, I don't think it's like the more conservative one, if I remember correctly, but I'm sorry about that.
Yeah, no, that's fine. I'm just wondering if maybe using centilloids as a continuous variable might parse out some of that MCI findings that you observed.
Yeah, absolutely. Actually, it's like it was a question we had initially, whether or not to separate like the amyloid positive and negative, or to include both of them and make an interaction with amyloidosis continuous. Or dichotomized. And we prefer this route, to be honest, because it was, like, for us, it was a way to look at the effect of this this effect in the amyloid positive group. But I agree, it's probably an interesting way to say, and I prefer, when it comes to interaction, to look at this continuously as well.
For Dr. Leffa, I'm wondering, we know ADHD is a highly comorbid disorder, especially with anxiety. Did you see any, or do you suspect any relationships with any mood symptomology?
That's a great question. Actually, they're not just psychiatric disorders, but also ADHD is associated with more vascular risk factors, and also hypertension, for instance, which might be confounders in this association. However, in ADNI, we do have some data about that. So we were able to control, for instance, for depressive symptoms, and results were still the same. And we were able to control for the vascular risk factors that we had in ADNI, and it seems like the results were still the same. And also for education, so ADHD is associated with lower education, which of course is also a risk factor, but still the results, they are slightly lower, the associations, however, they are still present. So I think they have an effect in this comorbidity, but it seems like it's not the only thing, based on the analysis.
Yes, microphone 2.
Hi, Zamboni from Modena and Reggio Emilia University. Specific variants of Alzheimer's disease, because I would expect something more. The closest association would be with the behavioral dysexecutive variant of AD, and whether, and this is my ignorance, forgive me, whether there's similar association with FTD between ADHD and FTD, please.
Mm-hmm. So the GWAS, they measure the genetic correlation between ADHD and Alzheimer's disease, and they did not find significant results. So it seems like genetically they are not correlated. However, there are some SNPs, and I don't know on the top of my head, but there are some SNPs that kind of influence both Alzheimer's and ADHD. I'm not entirely sure which ones right now, but basically, if you do the genetic correlation test, it's not great. However, some SNPs may influence both Alzheimer's and ADHD. I'm not entirely sure for the other diseases, neurodegenerative diseases. I think they didn't test, honestly. I think it was just Alzheimer's.
I had another question for Jeffrey.
With the poster I showed with my colleague, that's what we did. We separate the 12 different neuropsychiatric symptoms. But in this particular case, since we had, I didn't want to expand the number of comparison of models, so that's why we use only the total score. So yeah, no, not in this particular case. But with my colleague, that's what we tried when it comes to, we made some survival analysis over the 12 neuropsychiatric symptoms using awareness, like presence or absence of awareness. And we found some interesting results in MCI. It was different. We made separately MCI, CN, and dementia participant. But in this particular case, we went only with the total score.
Number one.
I've also got a question for Douglas. I was wondering, did you control for symptoms or disturbances that may relate to both of the disorders, like, for example, sleep disturbances?
No, we didn't. We didn't have the data.
Oh, okay.
However, that's an interesting question, that sleep might be also a confounder in this association. However, unfortunately, we didn't have the data, as far as I'm concerned, to do this analysis, but it's definitely something interesting. Thanks.
Do we have any more online?
No, there's no more online questions.
Oh, there's someone at microphone 4. Oh.
So out of curiosity, for the study participants that we focus on now with ADHD or what have you, I guess we've had a couple of decades for treatment options, but perhaps as they were growing up, they wouldn't have had access to some of the things that have allowed those of us with attention problems to exist in society. Have we done more recent or updated cohorts that maybe would have had sort of long-lived treatment to see if that help stabilize some of the increased risk for MCI and AD?
So actually, among the oldest ones is actually in Pittsburgh. So we have the Pittsburgh longitudinal cohort, and those individuals have been followed since they were around 12 years of age, and they are now in their early 50s, I would say, and they were mostly treated with stimulants. So that's the data we have. They're still young. However, we do plan to try to measure biomarkers of Alzheimer's in those individuals on their early 50s and see whether we can find any results and maybe follow up those individuals until older age. That's what we are working right now. But I think in the world, that's probably the oldest one, the oldest cohort.
Thank you.
And did you also look at, for that 2% of older individuals who have diagnosed ADHD, medication prescribing levels at that age, given that we mostly hear about overprescription of drugs at younger ages? This is a lot of what we hear about it. Was there anything that you came across around prescription of ADHD medications in older age individuals?
So that 2.1% is actually if you go to the patients and try to make the diagnosis. So in fact, if you go to the community and see how many people, older adults, have the diagnosis, it's very, very low. This is like the prevalence if you go and do an assessment with that population. So we believe that's the true prevalence. However, medication rates in older adults is extremely low. There were some concerns also about cardiovascular effects of the medications, which actually the most recent studies show that it's quite safe in that regard. However, it's very low for older adults. And for adults in general, it's also not so high.
Aubrey, there's a comment for you. Knowing that flotazepine is not a good tracer for early tau deposition, I suggest, I don't know who suggests this, but that you look further into this, continuing your project.
Yes, yes, that's a very good comment, one that we have talked about extensively throughout this project. I think the hope is to use newer tau tracers like MK6240 that have lower off-target binding, right next to these early regions. We've also talked a lot about the fact that the amygdala, when outlined, can be quite small. So these are definitely limitations of the study that we're hoping to look at further and correct for in future analyses. So yes, that's a very excellent point. Yeah. Microphone 2.
Hi, Olivier Piguet from Sydney University. Question for you, Aubrey, about the amygdala segmentation. The amygdala is functionally and structurally distinct and composed of different subnuclei. Have you looked at the different subnuclei within the amygdala and whether there are some differences in tau deposition? And the second part is more a comment. The output from FreeSurfer is somewhat unreliable with subcortical segmentation, and so
fact that these are quite small regions, I think we're still wanting to look at this further, kind of as in reference also to the last comment too. This is definitely a limitation of the study. We are looking into doing tractography and looking a little bit more at the projections from the amygdala, and that's a really excellent point about a specific nuclei. So I think we'll want to look at that further. We have not yet, though. Thank you for the suggestion.
And just a comment about the pixel-based analysis. There's a software called MR-Trix that allows you to do that.
Just with the regular diffusion scan?
Yeah.
Okay, thank you.
Yeah, thank you.
Okay. So there's no more questions online. No. For attending and online as well, and enjoy the rest of